Assalamu alaikum, everyone. My name is Nadiah Mohajir, and I'm Executive Director of Heart Women and Girls.
Assalamu alaikum. I am Kamilah Pickett, and I am a director of the Community Health Campus.
And we are so excited to have you all join us for this final conversation. Maybe it'll turn into an additional series, but for right now, this is the final piece of the conversation. And just to recap the first conversation, we discussed, really thinking about how you build trust as a community and what health looks like. And in conversation 2, we moved into using that as a framework to really think about, what is the history of communities of color, and in particular, Black and Indigenous communities with the healthcare system in this country, and why is it that, communities of color delay care. And finally, we're going to really think about some of the concepts that we drove home in conversation 1 and 2, and really use that as a foundation to look and explore some real life examples of how it's playing out in current day, in particular, looking at maternal mortality outcomes for Black mothers.
Right, and just to reiterate what we said in the first video, the reason why we're having this conversation is because it's important, right? Heart has a particular focus on educating about sexual and reproductive health. And for the Community Health Campus, I focus specifically on Black Muslims because those are the communities that I know. And we deserve programs that center us intentionally, unapologetically, because it makes public health sense, but also because it's the right thing to do. And it's important for us as communities to acknowledge where we have shortcomings, where there are barriers. And even as Muslim communities, there is no such thing as one Muslim community. We are multiple communities with multiple concerns and multiple barriers to being as healthy as we would like to be. And it's important for us to have these conversations and to kind of unpack some of the issues that we face and to look at solutions. And I will say from the outset that some of the things that we talk about when it comes to health, particularly health when it comes as it relates to Black women, can kind of seem like gloom and doom. The stats, they just ain't good, right? Like it's not looking fantastic, but we're still here, right? Like our communities find a way to thrive, and we figure out ways to fill in gaps where they exist in healthcare and access to healthcare, and we figure out ways to support each other, and we bring joy to it, even in the midst of all of the structural barriers that exist. So I just want to say that at the outset, and then kind of talk about more about what this looks like in present day.
And I think, one of the points that you brought up about, yes, it's gloom and doom and we're still here, I think speaks to the importance of, community-led change that we've spoken about in the first 2 conversations, and really thinking about, what is it that's happening in a lot of these communities that is contributing to their resilience and their innovation in really addressing some of the real healthcare issues that they're facing. And I think that, this also uplifts the importance of public health education and public health initiatives, not to be a one-size-fits-all, and to really think about what it means to design something that's tailored to the unique needs of a community, and to design something alongside with the partnership of that community, and not necessarily have a top-down approach where you're being told what to do in order to change your situation.
All right, because I think a lot of times public health professionals, we like to think of ourselves as advocating on behalf of people, or we advocate for people, but you need to be advocating with people. That's the only way that you will have community buy-in. That's the only way that you can ensure that the programs you're designing are actually working, that they're working the way you intend them to be. And then it's a way for you to kind of check yourself, right? It's easy to to know something theoretically and think that, this is the best solution for this community. It's a whole different thing to actually be in community with people and talk to them and figure out what it is that they think is best for them, and what it is that they think will work best. That's the only way that initiatives are effective and impactful.
Absolutely. And I know that, the first two conversations we threw out the term health equity a lot. And I think it's important. I know we've discussed it a lot, but really remind folks and how we can simplify the term and how everyone can understand the term equity. We don't want it to be limited to just a public health setting, but rather really thinking about, how is it that we all can work towards equity, and uh, how is that necessary to sort of uplift at every table and involve all the communities, so that that word is not just living in the ivory tower of academics and public health professionals, but rather it's a term that we all can use freely and in a way that we actually really understand what it means. And so I think I wanted to take a few minutes to just really break that down and really simplify this term so that it's tangible.
So health equity means valuing everyone equally, right? But then considering efforts that specifically address avoidable inequalities. And so that's historical and current injustices, and it is eliminating healthcare disparities and access to healthcare disparities. So it kind of goes hand in hand with what are called social determinants of health. And those are things that impact your health outcomes. So it could be your socioeconomic status, your environment, cultural conditions, your living and working conditions, your community networks, your individual lifestyle. All of those things are your social determinants of health. And so to design programs that are equitable, and that focus on health equity, it doesn't mean we want one group of people to be healthier than the other. It just means that we need different things in order to be healthy. That there is a level of optimal health that exists for everyone. And in order to get there, certain communities need different things.
Mm-hmm. Absolutely. And, one of the other things you mentioned, social determinants of health, it's really important to think about root causes of what's happening, right? And being able to see not just what is happening with that individual person, but also from a systemic lens, and seeing, are there other environmental factors or social factors or factors related to their faith that is also, sort of contributing to their healthcare seeking behaviors or their attitudes towards getting help about something, and also perhaps their healthcare status in general. So like an example I like to use a lot is when doctors start noticing an increase in pediatric ER visits due to asthma. Mm-hmm. And you can treat the asthma, and then lo and behold, the kid comes back in a week, right? And so there was a shift in thinking where these doctors realized that, like, maybe we need to start exploring what's happening in their home. Is there lead? Is there other toxic, toxic exposures in the home that is actually contributing to the asthma more so than their immediate, than treating the immediate healthcare situation that's happening in the ER. So really thinking about crisis intervention alongside like long-term prevention, and really truly the way they were able to reduce these hospitalizations, or recurring hospitalizations rather, was to address the home environment more so than just handing a medication to the family.
And I think the caveat to that, or the nuance to that conversation, is that a lot of times when people talk about things like that and they say, okay, well, it's not an issue with the kid, it's not an issue with the adult, it's an issue with their home environment. What that language does is still put the onus on the individual. Yes. Right? It still makes it seem as though it's a personal failing. Like, yeah, maybe you can't help that you live in a place that, has lead paint in the walls, but maybe you can, right? And so it's preferable to use language and to use a framework that looks at the structure itself, right?
Mm-hmm.
So it's not that, there is a problem with the home environment, it's a problem with the building.
Right.
It is a problem with, policies that allow landlords to, get away with these types of things, that they don't have to come in and fix structures. They're allowed to run buildings that make people sick. That, schools in certain districts are allowed to be deteriorating. So that it may not even be the place where the kid lives, but if they are school age and they spend the majority of their waking hours in a building that has mold, that has water that is contaminated, that is drafty during the wintertime, these are things that are, contributing to the child's poor health. And those are systematic things, right? Like, it's not, their fault. It's not their parents' fault. It is a symptom of a system that allows those types of larger inequities to exist. And they have rippling effects.
Mm-hmm.
Right.
Yeah, and it's and definitely that structural lens is super important, to remove that individual focus and really think about why are certain communities showing up with these inequities or these disparities in the hospital. Why are certain neighborhoods having higher incidences of a certain health issue compared to another neighborhood, and really being bold and looking at all of the differences, right, from socioeconomic status to environmental, racial identity, policies, redlining, all of the stuff that poverty, all of those things that have deeply contributed to perpetuating a lot of these health inequities to continue.
I'm telling you, man, if you start in order to do any of this work to improve people's health mentally or physically or socially, you got to start at racism.
Yep.
Like, if you are not tackling that, you are just leaving too many other things alone. You're leaving too many other things to fall by the wayside. That has to be the heart of every initiative that purports to improve people's well-being. It really does go back to that, right? It's like a cloud that is like a fog that's kind of surrounding everything, and you have to start there.
Yeah.
Yeah.
And often it's the place where most folks kind of hesitate starting from.
Yes, don't want to be. Well,
but as we're going to explore a little bit deeper when we talk about maternal health in particular, we're going to see that even research is showing that the impact of racism itself on the woman's body is enough to contribute to some of the poor health outcomes that they're seeing with respect to maternal mortality. And so it's really, really important to look at the impact of race, and even more than that, the impact of like the structures that support racism to continue, like the poor policies and like the landlords being able to get away with, treating certain communities poorly, and all of that. So absolutely. I mean, I think it's also, there's important to think about, how health equity really has a component of, active community engagement, and really thinking about what building, relationship building looks like and barriers to engagement, and how that authentic representation and inclusion can exist. It's not enough by saying, oh, but we had, so-and-so at the table when we were designing this, initiative, or, also thinking about just other barriers to participation. If you're going to have all of your community town halls during the workday when folks can't take their day, take time off, that in and of itself is an equity issue that needs to be addressed.
Absolutely. And it is the difference then between diversity and inclusion and equity. So it's not just that you look around the table and it looks like a Gap ad, and it's not just that, you you give people some modicum of power. It's that you're actually listening, that they are able to advocate for what they need themselves, right? And everybody is doing this in an equal way. And for some of us, that requires us to just rethink our vision of community. A lot of research, well, there's not a lot of research about American Muslim health. There's an uptick in the recent years, probably the last maybe 10 years. There's a slight uptick in research that focuses specifically on American Muslim health. But a lot of it does not touch Black Muslims in particular. And if we are included in the studies, it's a very small number. And I think it's because people, when they approach faith-based groups for research, they think, oh, well, if I'm talking about Christians, I'm going to go to the church. If I talk about Jewish people, I'm going to go to a synagogue. If I talk about Muslims, go to a mosque. When we know that, as far as people who express a certain faith identity, not a lot of us are going to masjids on a regular basis, right? It's not the center of our community in the way that people would like to assume that it is. In some places it might be, but a lot of us are not connected to masjids in that way. And it could be because there is not a place that you feel completely comfortable being all the time. It could be that you live in an area where there isn't one, right? That is close to you, that you have to drive, 50, 60 miles to even go to Jummah, right? And so if interventions are only focused in masjids, then you're missing people. And if we are not willing to look at smaller groups of people as community, like your neighborhood is your community, your extended family is your community, the women that you get together with to walk around the park on the weekend, that's your community. And all of those groups of people that you associate yourself with have a part in how healthy you are. If not physically and mentally, then definitely socially. Your attachments to people say something about how healthy you will be as you age, how sharp your mind will be as you age. And these are all things that we have to think about. And these are places where we need to look to not only get information from people, so that makes our research richer, but also that we want to focus interventions. And when we think about designing programs that are meant to make our communities healthier, then we have to think about, community in different ways.
Mm-hmm. Absolutely. I think another, important piece to this is really thinking about and this goes back to what we talked about of not just treating the individual patient, but really thinking about an intervention that is, through different levels. So looking at individual level, community, and systems, and how all of those can work together in partnership. So to use another example of for example, getting immunization rates up, right? You can do individual patient education, but then you also need the partnership of, health educators, of schools, of policymakers to really help create and facilitate the reduction of low immunization rates and things like that. And I think that is also, and then of course you need the research to back it up of why it's important to get the immunization. So, really
also need gatekeepers in communities, right? For certain communities in which that's even a taboo thing, or it's kind of a thing that people are leery of, you need gatekeepers in those communities. So it may be a particular sister in a community that people go to for holistic health, that you need to talk to that person too, right? Because she might be giving information to people in the community that tells you, I don't think you should be vaccinating your kids. Yeah. You need to talk to people in particular communities that hold weight, who have opinions that people listen to, right? And it's not always going to be the imam, right? It's not always going to be advice that comes from a khutbah at Jummah. It could be the sister that's in the back serving the food who really holds the weight in the community, right? She's really the person that people are listening to when it comes to just regular everyday advice. So yeah, you want policy people to be able to talk to, you want physicians, but you have to include other people too, because that's how people take information. It's like, yeah, it's one thing if my doctor says it, I'm definitely going to listen. I mean, I'm not talking about me personally, like clearly I'm going to listen, but like, yeah, I'm going to listen to my doctor says something, but if my mama says it, yeah, right? Yeah. If my auntie says it, definitely.
Yeah, and what to do, how to make sense of the information when it's conflicting, right? And really also, like, speaking of the gatekeepers, or, you know, the auntie who's holding that information, it's also important to speak her language and, like, really, you know, tailor the messaging so that it's received and not just rejected, right? Because of the mistrust that a lot of communities of color have with the healthcare system and with pharmaceuticals. And, you know, it's not enough to just say, well, you need to vaccinate your kids. And then, you know, but, you know, what about the pharmas that are actually providing the vaccination, right? And so there's a lot of trust building and meeting people where they're at and speaking their language and using shared values as a way to actually mobilize that change and to facilitate, you know, being open to the public health messaging that you're trying to communicate.
Yeah, and it's not just that, it's all types of things, right? It's mammograms, it's getting yearly pap smears, it's getting prostate exams, all of these types of things, right? Anything that is kind of optional that you should go and do, but nobody is forcing you necessarily to do, but we know will improve your health, like those types of things. And not and I always like giggle when I hear commercials on the radio or on TV, and they use like this certain vernacular, like it's a rap that's telling you should go and get something checked, and it's like, who's listening to that, right? Like, who is that particular campaign reaching? My mother is not going to go to the doctor because somebody like put together a rhyme over a beat telling her that she needed to go get a mammogram. That's not going to work for her, right? Like it's also just really hokey and cheesy. So no, that's not what we mean by speaking your language. We mean authentically talking to the people that need that information in a way that makes sense for them, and that is not based on some weird stereotype of like, oh, you know, if I put a jingle to it, like this will clearly work, right? Like all I need is a hot beat and then everybody is gonna be completely healthy. Probably not.
Mm-hmm. It's really about finding innovative ways to create that almost culture shift, right? And really helping people kind of take control of that change themselves and of that message themselves, and not, again, using a top-down approach, because that very rarely works. There's a really great framework that I wanted to bring into this space by two really brilliant public health minds. In 2010, they created it, called the R4P network, or R4P framework, sorry. And by Hogan and Rowley, professors Hogan and Rowley in 2010. And really it's like it's 4 R's and 1 P, hence the R4P framework. And it's just an easy way to really, you know, think about how we want to think about designing some of these interventions. So the 4 R's are repair, restructure, remediate, and remove. And then the P is provide. So when we say repair, this is where we're talking about some of the historical trauma that we discussed earlier. Really thinking about what is the structural and historical trauma and oppression that could be contributing to this healthcare disparity, and how can that be sort of addressed in order to for people to begin thinking about accessing healthcare and maintaining health and practicing healthy behaviors. So really thinking about removing the focus on the patient, on the individual person, or individual community, and really thinking about, okay, what is the shared history in this group that we're trying to think about changing outcomes in. Then there's restructure, thinking about, how can we restructure where we live, work, and play, so that the root causes are removed. So going back to the conversation about asthma, thinking about what is happening structurally in that building or in that neighborhood or in the schools that those children are attending. How can we restructure those spaces so that the root causes of disease or poor outcomes is being removed, or is being is being removed. While you wait for that structural change, really thinking about what is it that we can do to remediate the adverse effects that these people might continue to experience. And then finally, this is where, addressing racism comes in, and really removing, some of the structural oppression. So removing power imbalances, removing racism, classism, all of those isms that continue to also sort of contribute to some of these poor outcomes. So really exploring questions like, where is racism operating here? How do I Yeah, exactly. How do I restructure and undo and dismantle some of the power imbalances that are happening, in the space or in the community that I'm trying to create change in? And then finally, providing feasible interventions for the communities that you are trying to sort of create this, reduce a disparity in. And so that's just it was helpful for me as I was studying the public health frameworks to really come across this. I thought it was a really I don't like to call it a formula, because there is no formula, and it's starting to get people to think about the questions that they should be asking when thinking about reducing poor health outcomes.
Right. And I know you and I talked about, how to make this a less academic sort of framework, how, to kind of simplify it. But I think you did a great job in doing that. And it really is something that everyone can use. People that are formulating like large public health interventions, and then also people that are doing something just for their local community or a small group of people. It's simple, repair, restructure, remediate, remove, provide. You could possibly put it over a hot beat and make it into a jingle that people could remember in order to really think about how to approach systems that exist and dismantle them, create new ones that work more effectively, and do all of that, with the input of the affected or impacted community.
And going back to what we discussed, it's addressing change at every level, right? Individual, community, and structural. And I think that is what makes this framework that much more important to remember when we discuss things like this. So yeah, so just taking all of that into account, really we wanted to shift a little bit and talk a little bit about, gender, race, and health disparities. And we discussed in the last conversation about some of the reasons that women of color do have a tendency or are more likely to delay care, and what are the barriers to receiving care. Some of them is health. We know that healthcare is more expensive in general for women. Yes, there is some level of coverage with reproductive health care, and then not all of it is. Contraception, family planning, if infertility, all of that can, having a miscarriage, pregnancy loss, all of that is expensive, and continues to be expensive, especially if you don't have insurance, and even if you have insurance.
Yeah, it is expensive to have a uterus. And even just that's just one part of our healthcare, right? I think when people think about women's health, that's all they think about. We have an entire body outside of just that. And so when you add up the cost, it is more expensive for women to obtain healthcare. It is more expensive when we are insured. It is definitely more expensive when we are underinsured or have no insurance. And having inadequate health insurance is sometimes worse, right? Because you just don't go. Women just don't go. If they go one time and they find out that something isn't covered, or they get a huge bill that they weren't expecting, or they have a deductible that is thousands of dollars, that is completely ineffective, right? It's almost like having no insurance. And so people use it just for emergency purposes only. A lot of people still don't know that there are tons of preventative measures that are covered by law under healthcare as it exists now. That there are things that you can go to the doctor for and not be charged. And a lot of people don't know that. But then there's also, after you get past the issue of whether or not you have insurance or how much it costs, then there is the time cost that is needed to dedicate to going to the doctor. Doctors operate on a regular business schedule. If you have a job that does not allow you to take that time off, or if you work for an hourly wage, then it's not feasible for you to do that. If your appointment is at 10 a.m. and I'm not talking about individual doctors. I understand that it is a symptom of the larger healthcare system. But if your appointment is at 10 a.m. and you sit there until 11 to even see anyone, and then you go in the back room and you sit there until 11:30, and the doctor comes and they talk to you for 10 minutes, and then, that's 2-3 hours. That doesn't even add in the commute that it took you to get there. Most of the time is spent just waiting. And most people can't afford to dedicate that amount of time to do it. And even if they can, you may need to go to the doctor today because there is an issue you have today, and you call and you can't get an appointment until 2-3 months from now. And most people will just say, you know what, that's all right. I'll deal with it, or it's not that bad, or 2-3 months from now, I don't even remember what it is that I needed help with. And when I used to organize back to school fairs for children and youth, I would make sure that I had providers there that could do screenings for adults, because if anything, people would take care of their kids. They would make sure that their kids got the shots they needed to go back to school, to get hearing and eye exams. If they were offered for free, they would take their kids. And so it was a time that you could actually get parents, because in the normal course of life, it's just too much to assume that people can carve out time in their day to care for everyone that may be in their care. Whether it's, a sibling that they're caring for, or it's children, or even in some cases it's parents. Our families all look different, right? And being able to take time to care for everyone else that you're responsible for sometimes mean that you care for yourself last. And that happens a lot with women. And then you throw in other factors, language barriers or immigration status, discrimination that women may face because of their ethnicity or because of their faith practice. It's a lot. It could be overwhelming just to try to care for yourself within the healthcare system as it looks now.
And not to forget, one of the things that we talked about last time is just we are socialized to not believe women ever in life. And in particular, so many research studies have shown women going for reproductive health pain, pelvic pain, severe pelvic pain with their cycles and their menstruation, or bleeding for months and months and months, and being told that nothing is wrong, or that they're being dramatic, or to tough it up, and this is just a part of life. And so and this kind of socialization happens the moment you get your period, right? Mothers and older sisters and other aunties in the community will, socialize the girls who are experiencing pain with their menstrual cycle to deal with it, because it's something that will happen to them every month. And the sooner they accept it, the better it's going to be for everyone. And that has resulted in, things like women not being diagnosed with serious and common reproductive health issues like polycystic ovary syndrome or endometriosis for years at a time.
Years, decades even.
Yeah, years and decades at a time, where the doctors are more willing to remove a uterus, before actually trying to treat and diagnose the issue. They'd rather just remove the uterus, which is, they believe, will solve everything, even though that's not really looking at the root cause, which is that women just weren't being believed, and this is a common enough reproductive health issue that should have interventions being designed.
Right, and it's and the socialization when it happens, within a family unit, is not always malicious, right? Sometimes it's just because if I see my mother and my aunts and the women in my community always have just these really horrible menstrual cycles, right? Or everybody is in pain, and everybody is throwing up, or everybody's kind of curled up in the fetal sack. I just think that that's how it's supposed to be, right? So we're all misinformed. We all have a skewed view of what it should be during that time of the month. And so, that's one type of thing that happens. It's like, why is somebody going to take me to the doctor if that's something that they experienced and nobody ever took them to the doctor? And then, I have had friends, I know women that I have worked with who do go to the doctor, and the doctor doesn't believe their pain level, right? Like, they ask you on a scale of 1 to 10 what your pain level is, and a woman will say 8, and the doctor will say, it can't be 8. If it was 8, you would be on the ground writhing in pain, right? There's no way it's an 8. You're exaggerating. It's probably a 2 or a 3. And it's like, no, actually it's an 8, but I don't have the luxury of lying on the ground in pain. I have things to do, and so I just do it. And that, that socialization informs how people interact with the healthcare system, and whether or not we even choose to go, right? And it is overwhelming, and it happens from, I'm in the worst pain of my life, to I just think something is wrong with me, right? Like, my chest feels fluttery. I'm not really sure what that is. It probably is nothing. Which is why women tend to have, heart attacks that are undetected, and have these symptoms that go on that no one recognizes, because they're different from symptoms that manifest when men are having a heart attack or about to have a heart attack. And it just isn't something that is widely talked about, because I think people feel as though men have a certain stoicism when it comes to being in pain and health. And that's like the popular thinking, right? Like, you see TV shows or movies, and guys are like, oh no, nothing is wrong with me. My leg is just hanging off. It's fine. I'll spray some Windex on it and it's cool. Or if they get a simple cold and it's like overblown and they're like a baby. But you don't really see those depictions of women in pain, right? You don't see those depictions of women needing care and what that looks like. Because the assumption is, do we need care at all? Right? Or if we do, we just kind of suck it up and move on.
And I think this self-doubt piece that you're talking about is also really important. I mean, there's often, like you said, there's oftentimes people do feel symptoms in their heart, or, whatever they're feeling. And it's like, oh, well, it's fine. I feel this all the time, or I don't need to go to the ER. Like, do I really have the time to go to the ER right now? And all of that stuff. And that is the self-doubt that, leads to being diagnosed later than you should, or being diagnosed with a late stage cancer, or what have you, because we're taught to just not even believe it. Like, not just that the whole other world doesn't believe us, but we don't believe us.
Yeah, to not
Because,
believe ourselves.
yeah.
Yeah. And I don't want to frame this conversation in thinking that, when we're talking about women's health, that the women that we're talking about are necessarily mothers, and that, they are in a traditional family unit, because it happens to single women as well, right? It happens to women who don't have children, or have no desire to have children. These are still issues. And that's kind of the crux of the problem, that it doesn't matter if women are in a relationship. It doesn't matter if they're single, that they're still having these health symptoms. Although I will say the single women tend to live a little bit longer, because they don't have the stresses of taking care of everyone else. But that doesn't necessarily mean that they're significantly healthier, that they're not still having issues, right? The statistics don't look super great.
Mm-hmm. So just moving on to some of the final pieces of our conversation, just really looking at, how this is actually all of these different things that we've talked about is really manifesting in maternal mortality outcomes, particularly for Black mothers, and, really wanting to explore that a little bit. So, we know, for example, that this is, there are several studies in the past couple of years, and really incredible journalism that has, happened in the last couple of years, that has really shown that this is a very big concern. Why is it that Black mothers are dying at, a rate significantly higher than their white peers? And even when you control for, socioeconomic status and all of that. And we also know, for example, the example of Serena Williams, who is rich and famous and well-known and has access to healthcare. It doesn't discriminate. She also experienced some, poor maternal health outcomes that she had to advocate for herself so that she wouldn't actually end up dying as a result. And so that is something that I think is also important to look at, is what is happening structurally that is continuing to perpetuate this health disparity. This goes back to not believing women. This goes back to implicit bias that healthcare providers have, in the way that they approach their Black patients, and and things like that. So I kind of just wanted to put that out there, and open that part of the discussion up, is really what's happening, and how can we start to think about what the kinds of things that we need to sort of influence in order to move the needle.
So a professor came up with a term called weathering, and it kind of explores the way that social disadvantage impacts your health. And for this conversation in particular, it's kind of like, so as a group, Black mothers in their mid to late 30s have 5 times the maternal mortality rate of Black teen mothers. Although the older mothers have, greater educational or economic resources and access to healthcare, all of the things that you're supposed to have, in order to be able to carry and birth and raise a healthy child. So why does that exist? Because it's not the case for white women, and it's not the case for Latinx women. Why is that the case for Black women? And it is the impact of racism and implicit bias, right? And it starts not the weathering. It doesn't just begin with conception, and it's not just through the process of carrying a child. It begins before a woman even gets pregnant, right? It's the accumulated impact of racism, the accumulated impact of implicit bias that by the time a Black woman is in her mid to late 30s, she has experienced so much of this that she is actually having poorer health outcomes than a teenager.
Mm-hmm.
And that's horrifying, frankly.
Mm-hmm.
And, I think Serena Williams or Beyonce, they're examples of famous Black women, wealthy Black women, and women who have access to the very best, theoretically. And a prevailing thought is that if you have money, if you have access, then you have somehow managed to wealth your way
Mm-hmm.
out of the woes of racism, out of the woes of implicit bias, right? You have moved into another strata, and these things don't impact you. But guess what? Serena Williams been Black all her life before she got rich. Beyonce been Black all her life before she had money, right? And so these things take a toll. And if you are someone who is wealthy and you are telling a doctor that you are paying for top dollar, that there is something wrong with you and they're not believing you, hello, like that's an issue, right? And so when we hear about the stories of wealthy, famous women who have access to the best, then you kind of have to think, what is happening to the rest of us that don't have access to the very best care? That don't have, the money or the luxury of choosing necessarily where we go to get care or who is in the room with us when we give birth, right? These are decisions that are not always under our control. And then what that care looks like after a woman has given birth, because everyone just focuses on the baby. And you have, a whole woman here who's just done something extraordinary. And so if you don't place focus on her health as well, studies have shown that it can deteriorate very rapidly. And those are things that we have to address. And not in a way that just says, okay, there's something wrong. And then there's Black women, there's something you should do. Because a lot of times that's where the intervention is focused, right, on the individual women. People tell you, well, you need to do all of these things. If you eat this and you don't do this and you walk this many steps and you do all of these things, then you should be good. And we know that's not the case. And it isn't just with birth, it's with all sorts of diseases. Black women get diagnosed later with cancer. By the time they get diagnosed, it's more advanced, and the chances of treating it are decreased. It just cuts across so many health states and so many disease states that everyone should recognize it's a problem.
And bringing up what you brought up just a couple minutes ago about giving birth and paying attention to the baby and not the mother. I mean, postpartum is something we haven't even delved into, and just how postpartum is minimized and how expensive mental health care can be as well. Even people with the best insurance have to pay co-pays and out-of-pockets and deductibles for mental health care services. Too many people say, I don't have a therapist because I can't afford to have a therapist, both because of money and time, because that means that you have to make a commitment to go to this person once a week or once a month and find the childcare and find, the transportation and take the time off of work and all of that. And so I think absolutely, not being able to look at it holistically is absolutely a problem. And one of the things that I've always wondered, and this is just because there's such limited studies out there, but I've always really been thinking about, okay, so we have this documented research that is showing a significant health disparity with respect to maternal health outcomes for Black women. But what does it look like if you're at the intersection of being Black and Muslim? And that I don't believe in this moment has been studied yet, but I think it would make for a really important study.
I have not found a study yet, and I have looked. And there have been studies that that look at Black immigrant women.
Mm.
And that is definitely a portion of our community, but it's not all of it, right? And so there seems to be the tendency to kind of segment it. But I would love to know what that looks like for Black Muslim women, as many segments of our community as possible. I would love to know what that looks like, and how we even get that information. And it's and not for any nefarious purposes. It's just, all of this is tricky, right? Like, you want to gather information from people, but then our communities don't have great history of people gathering information on us, right? Like, nobody wants to be out here asking people random information, or saying, hey, you want to come participate in this study and tell us all the intimate details of your physical health and your mental health? Probably not. Are you the feds? Like, who does that, right? Like, we don't have a good history with people asking us questions about our intimate lives. And that's like a real thing that we have to address. But we need this information in order to even begin to formulate interventions that have any chance of working. Because Black Muslim women, we sit at so many intersections, right? And we need to know what it looks like to have programs that are focused specifically on us, that are backed by the best science, the most applicable science, and things that we know work. And it's a tricky situation to navigate, right? Like, it's not easy. I have seen communities of women who do it, right? They figure out ways to educate themselves. They figure out ways to fill in gaps where they exist with healthcare. And they do it on in a small way, but it works. And so what does that look like? That can look like trained doulas that function in communities, right? And I've seen a couple of programs where they're like community doulas, where just a group of women will be trained to be a doula, so that if a woman in their community needs that help, they can have it through their entire pregnancy. They can have access to other women who can give them advice. And not just not advice that we think of that is just kind of superstitions or things passed down, but like medically sound advice, right? Because that's important. It can also look like, exercise groups that don't just exercise, but they actually check up on people. Somebody that you're accountable being with at a certain time on a certain day of the week, and you go for a run, and it's like the run is good for your physical health, but then it's also good for your social health to be with people who are going to expect you to be there, who are going to notice if, you're not in the best place mentally, right? Who can actually talk to you. It may be your brunch group. Like, if you don't like to run, it may be the group of women that you get together with to have brunch once a month, that you're talking to each other, right? And you're talking out maybe some issues that you're having. Because regardless of what we see on Twitter and Instagram, and I guess to a certain extent Facebook, everybody ain't doing self-care, right? Everybody doesn't have a therapist. Everybody is not checking on their mental wellness. It would be great if that was the case. And I think that, if you have a timeline, a Twitter timeline like mine, it makes it seem like, oh, everybody's really on it, right? Everybody's talking about therapy. Everybody's doing it. Love to see this. That's not the case in most communities, right? And so self-care as a mantra doesn't mean a lot if you don't have time to even relax, right? If you are not in a situation financially or emotionally to even do that. And so it requires us to think differently about what that looks like and how we can incorporate wellness, physical, mental, social, into the way we structure our lives and our communities, so that I am not only a guardian of my health, but I am, a helper to my sister. I am a helper to the people who are in my social circle. So social circles, whatever that looks like.
I really like thinking about self-care alongside community care, and really not separating the two and thinking about them as a simultaneous sort of practice. And also, just like you acknowledge, self-care has become so commodified. And, when people say self-care, they immediately think spas and manicures, when in reality, it could be like just what you said, your brunch group or an exercise group, or, reading a book together with your book club. I've heard of groups that want to raise awareness about elder abuse and domestic violence, and so they've started knitting groups, right, where the women will knit together, and then those issues will come up and they'll educate each other and exchange information with each other. And those are the kinds of community-led sort of efforts that we need to uplift and also invest in, because that is where the community care happens, and the relationships are built. And a person can take care of themselves, but then also remember that the person in their knitting group was also feeling lonely. And
Right.
so what can we do for them and make them feel cared for?
And just any group of people that you interact with pleasurably can be a source of support. It doesn't have to be complicated. It doesn't even have to be explicit, right? It is just the idea that in order for us to be healthy, our environment needs to be healthy. And it's who we surround ourselves with. It's what we give energy to. And when we are in positions where we don't have a lot of choice, right? Like, you got to go to a job you don't necessarily like, but it pays the bills. There, you got to deal with it, right? Or you have to live in a place that you don't necessarily like, but you don't have many options, so you just have to deal with it. In dealing with it, and in going through your day-to-day life, it is the people that you surround yourself with intentionally who can have the biggest impact on your well-being. Your friends might notice something about you before you acknowledge it yourself, right? Your family might do the same thing. And then you might be that person for someone else, and not in a judgmental way, not in a nagging way, but in showing actual concern for someone. And that's how we are healthy as communities. Healthy communities sprout healthy individuals, and in the contrast, healthy individuals make healthy communities.
Absolutely. I mean, I think this has been really a fantastic discussion. Is there anything else that you want to add before we end?
I just I will say this, that if you are in community and it is not supporting you in a way that makes you feel healthy physically, mentally, socially, spiritually, please search for other community. Make one yourself, right? Because it just speaks about what our larger communities look like. It should be spaces that we go, we feel like our best selves and we can be our best selves. And then I will also say that if you are in a community of Muslims and you are not concerned about the status of Black Muslims and Black Muslim women in particular, then you are A, whack, and you are B, not taking care of your community.
Mm-hmm. Mm-hmm.
Because we Black Muslim women tend to be the bellwethers. So if we're doing good, other people are doing good, and you should want us to do good.
Absolutely. Absolutely. Thank you so much for joining me today, Kamilah. I really appreciate the work that you're doing at Community Health Compass. And we're really, Heart is really excited to, continue to partner with you. And what I would like to ask those who are still tuning in to share with us any feedback that you have about these conversations, and also any future topics that you want to hear about, because I know that I had a blast doing this with you, Kamilah.
I did too. I love talking about this. It is exciting for me. I appreciate the opportunity to do so. And I look forward to comments, to engaging, and to shaping conversations in the future, right? That's the way we make this work.
Thank you so much. And let us know. We're looking forward to all your comments.
All right. Assalamu alaikum.
Assalamu alaikum.